Hello. Is anybody there? Hello. Can anybody hear me? Hello. Hello.
Hi, Adrian.
Hi, Michael.
Can you hear me okay?
Yeah, I can hear you just fine. But how do you join the public hangout?
That's my question. So is your Hangout active right now? I think I saw something on the Google Plus.
I am. I'm broadcasting. And I just invited you.
Okay.
But I was hoping other people would be able to join too. I don't know.
Let me see here. Well, it looks like...
Am I the only one?
I don't think so. It looks like, let me clear out of this one and see. It looks like you're on a different video thing. Let me see if I can just join up to this one if for some reason it didn't ring me here. So
I just clicked on the link. I don't know. Ah, there you are.
Yep, I'm right here.
And I'm not, my camera isn't on. Let's see why. That's weird. Just turned it off. Ah, there it is. Now I can see you.
I can see you now.
Okay, so how did you join?
Well, I think you were the one that initiated the video. For some reason, it didn't show up on my panel, and then I called you, and so it created two streams. Okay. I think that's what happened.
So I'm going to enter in the message here.
Mm-hmm.
Please send me an email. Give me an email address. I guess people can hear me to be invited to the video.
Oh, okay.
Right? I just put that in the chat for the group for the Hangout. So it's 11:03. Welcome anybody who's out there. But I guess right now it might be just you and me. I'm just hearing my own echo. Let me see what happens if I invite anybody else. Now we have 3 viewers. I'm going to put it in the email too. All right, so somebody just dropped off. That's weird. I don't know what that is.
That was my phone.
Oh, that's you.
I'll mute it.
I'm not in there. So here, let's put Michael Mashier in there. I will add Michael. I just did. Let's see if Peter is, if I have his email address. Getting off to a slow start here, but hey, there's a first time for everything. Hello.
Hello.
Hi, Michael and Adrian.
Yes.
Let me try and get Peter on here if I see his email. Let's see. Sunny. Where is Peter? Peter's email.
So this is recording, correct?
Yes.
Okay.
I should be clear that, yeah, everything you say will be public. Okay. Oh, hi there, Mike. Okay, let's add Peter if he's around. We're not doing too badly. It's only 6 after. Do I have anybody else? Let's do David in case. We're not doing too badly. It's only 6 after. Do I have anybody else?
There's Peter.
Here I am.
Let's do David in case. We're not doing too badly. It's only 6 after. Do I have anybody else? People are going to have to go on mute. David, in case. We're not doing too badly. It's only 6 after. Do I have anybody else? People are going to have to go on mute. David, in case. We're not doing too badly. It's only 6 after. Okay, so, well, we have a quorum. I don't see anybody else. I don't know. Suni, let's see, who was on the list that I was supposed to invite.
Michael Gill. Oh yeah, Sunny can attend, she says, so let's do her. Bear with me one more minute. So I invite everybody who gave me an email address. Michael Gill is the last one. And then we will get started. Okay. I think we're good to go. So welcome everybody. Thank you very much for showing up. Michael Chen. I don't think I've seen any of your faces, or maybe Michael's once before. So let me start off by going quickly through the keynote that I made, that 3-minute preview, so that you can stop me and ask questions right then and there. And then Michael will show us some stuff if he can. And do interrupt. I'd have no other agenda but to discuss about this topic. And I'm very glad that we had the New England Journal perspective that I posted in the thread today, because that kind of that's very timely. So here's my desktop, and let's do this. So I assume you can all hear me. If not, somebody say yes. Can you hear me?
I can.
Definitely.
Okay, good. And you can see the slides, I assume.
Yes.
All right. So we're talking about this architecture. I assume you all sort of saw the preview, and so I'm not going to dwell on the obvious. I think what's very interesting, if we succeed at this, is incremental adoption. That, you know, not everybody has to switch all at once, but any kind of FHIR-enabled EHR will still be able to play along. It's just that they're not going to have the single sign-on patient-centered experience, but they'll still be, in effect, contributing to a patient-centered EHR as best we can manage it. And so NOSH, Michael's open source EHR software, as any software, has this split, and we decided about a year ago to see what would happen if we made 2 copies of the same software and made sure that one of the copies only had information about a single patient and everything else stayed on the clinician side. So Michael can tell us how he did that, but these things are connected via a FHIR interface. As far as I know, or maybe that's still in progress, Michael, or is it done?
That is correct. The idea is that the architecture behind NOSH is that NOSH can talk to another NOSH via FHIR. There's also, for testing purposes, there was a direct type of API, separate API, other than FHIR, prior to their, before FHIR was mature enough. So I was using that initially, but it can go both ways. The idea with NOSH was that NOSH, when it first came out, had its integrated patient portal. And so being that it was web-based, it was actually quite easy to be able to morph it. Basically, the same version of NOSH, you just set it as a patient-centered EHR, and in essence, there's only technically then one quote-unquote practice, which is essentially just one patient chart. And you just disable the searching features for any additional patients because there's only one patient. It was actually quite easy to create a patient-centered NOSH because of the architecture that was already in place. And so that was the genesis behind the patient-centered EHR.
By the way, I'm being a bad host, and though I've been on the society list for many years, you haven't. So you want to take 30 seconds to tell our audience about you and who you are and NOSH?
Sure. Yeah, so I'm a family physician. I still practice in primary care. I actually work in a direct primary care practice. For about 10 years, I had my own solo practice, and that was where I first developed my ideas of developing NOSH. In essence, because I was frustrated with the EHR offerings that were out there, and that was about 10 years ago. And then around the time meaningful use came about, I became extremely frustrated to the point that I actually put out my own open source EHR, and I used it for my practice. And it's a web-based EHR, and I'll show you later on how it looks and how it works from both a patient perspective as well as a provider perspective. And it was built as an outpatient EHR. So there's clearly differences between the design of that to serve an outpatient workflow versus say, an inpatient or hospital workflow. And that by design is what makes it different compared to some of the other EHR offerings out there. And so, so that's a little bit about me and what I do.
All right, thank you. I'll go on. Oh, by the way, does anybody else want to introduce themselves? At least the other two people that can speak? Please.
I'm Peter Elias, family physician with 40 years on the front line, who's been, I don't have the coding chops to do what you did here with doing something, but it's been one of my dreams. I'm impressed.
Thank you. And that's one of the things that I also had about making it an open source project was my desire to go beyond just my own pet project, that I wanted to really push the envelope in terms of creating an opportunity for other physicians, even if they might be technologically averse, to really dive in and sort of like basically like a peer review. You know, the more that people are involved, the better the software will become, and I think that's what's essentially missing in health IT is because physicians don't have a voice.
Michael, you want to introduce yourself, and then I want to make a comment about what Peter just said, or what Mike.
That is the truth. Physicians don't have a voice. I did family medicine for 14 years in rural Maine, and then went back and did a anesthesia critical care residency, and I've been doing academic anesthesia and critical care for the last 20-something years. And a few years ago, we set up a nonprofit because we were so annoyed with the many things that were going on. But to focus on electronic records, I saw the implementation at one of these academic institutions of Epic and a rapid decline in the care and treatment of the patients that followed as people who were supposed to be taking care of patients ended up spending a lot of time taking care of computers and keyboards instead. So, and the folks who put the system in looked at you as if you had two heads whenever you had a suggestion as to how to make it work for us and for the patients. So it's good that physicians, and you in particular, are taking on that challenge. So I certainly don't have the technical knowledge, but I certainly know what we need in the hospital, and still doing the primary care as well. So,
okay, let me make a point here that's very important to what both of you just said. If you notice on the diagram, when we have a patient record that's associated with a patient, that, and you have more than one physician or more than one hospital, as in you see here, dealing with that same patient record, it's going to get impossible or very confusing if every patient shows up differently when the clinician goes to their record. One patient, it's as if every web browser that you went to use or every website you went to use was completely different the way it is maybe at some banks, for example. So having the patient record, the patient NOSH, be open source is almost mandatory, not just because of the peer review issues and all the other goodness of not having to hide bugs and all this kind of stuff, but because it means that people are not going to introduce gratuitous changes just for cosmetics or for trivial ones, because they can obviously reuse the code when the patient NOSH is open source. So I'll move on unless people want to dwell on that for a second. What we have here, so in other words, the EHR, somebody that, an EHR that's not patient patient-centered record aware, would still have a FHIR interface, but the functionality would be quite different. So this is the current model. We all know it. Patient is expected to go every different portal, and the health information exchange is often proprietary. Here's what happens when we add one of these split patient-centered EHRs and separate physician practice component. We talked about the single sign-on, so that at the point when you click to select a certain patient focus, the physician is automatically redirected to the patient-owned or the patient-controlled EHR, and using standard OpenID Connect single sign-on. And I don't know why the slides are not advancing. Let's do it this way. And they continue to work on the patient EHR. To the extent that the physician's EHR and the patient's EHR are coordinated, they really can't tell the difference. It's the same number of clicks. So what this ends up looking like when you add a consent management service, which I call HIE of 1, and that is a standard-based FHIR authorization layer based on the user-managed access, or UMA standard. This, in effect, gives the patient a combined consent portal and as well as a combined records portal. And these could be on separate machines or it could be on the same machine, but they both share this characteristic of being owned and controlled by the patient, and ideally open source. And that's, I think, the last slide, which basically summarizes kind of this idea that patients and clinicians are using the same API. And this, by the way, is the subject of work that I'm doing with the API task force. And we can talk more about sort of the regulatory and HIPAA drivers that are going to enable this kind of shared patient and clinician access to the FHIR API, and then the stuff about the combined portals that I just mentioned. So let me go stop the screen share now and hand the controls over to Michael, who is going to show whatever he wants to show.
Okay, great. Feel free to interrupt at any time if you have any questions. What I'm going to do is demonstrate and show a little bit of NOSH, both from a provider and a patient perspective, and also a test run of what what I've developed as a preliminary single sign-on solution for physicians, if they were to use that to integrate, if they had their own NOSH, or even if they did not have NOSH, if they wanted to use that as a way to collate all of the patients' patient NOSHs that they've collected, and that is a good demonstration of what can be done with the technologies with FHIR and UMA. So I'm going to go ahead and share my screen here. Okay. Can you guys see this? Yep, okay, great. So this is the login screen for, this is actually a patient NOSH that is installed on a DigitalOcean droplet. I'm calling it, it's coupled with an UMA server, which is the User Managed Access Server that was developed by MITRE ID Connect. And so I'm going to go ahead and show you first from the patient perspective how this works. So from this initial login screen, you'll see you get to choose if you're the patient or you're the provider. And so from a patient perspective, you'll see here this PNOSH UMA server. So it's logging in to the UMA server as an OpenID Connect protocol. And so I'm going to go ahead and log in. So this is the dashboard, if you will, for a patient if they were going to access their personal health record. So on this side are some commands, things like viewing your messages. So these are messages that are to and from participating providers that have access to this NOSH instance. You can edit demographics and insurance, so basically any updates in terms of contact, emergency contact, things like that can be done here. There's a list of active medical issues, and so it shows in a grid format. And then when you see it in the provider format, you'll see it displayed a little differently, and there's the ability to enter information as a provider. And so the key part of what makes this one a little different is because of this sharing icon, is share your chart. And this allows the patient to be able to register the resources. So these are this grid of resources like demographics, medications, providers, conditions, allergies, and immunizations are all part of the FHIR standards. And so you can see here, for instance, if I click on demographics, this patient has provided access to, this is to me as the physician, at this email address. And so you'll see later on that by giving permissions here with these scopes, these are FHIR scopes, that they will be able to access any part of this record from a different web-based system. And you can also, as a patient, send an invitation to a medical provider if they wish to. This is tied in directly to which I'll demonstrate later, this MD-NOSH gateway, which is the single sign-on service for providers. So if they click on this, I'm just going to type my name since I'm the only physician in that gateway. So they can type in any part of the name. of the physician, and if there's a match and they're established on MD-NOSH Gateway, then they will be able to see the provider practice information and confirm that that was the provider that they wish to share their record to and allow access. So, so you just click on that and send invitation, and that's how simple that works. Any questions so far before I proceed to the provider level, the provider version of NOSH?
It seems to me that the scope is pretty geeky for the average patient I see. I can see eyes spinning and sweat breaking out on the brow when patients look at that.
Right, I agree, and there's definitely work to be done there. I think that the scopes are basically just delineations of that, like that one resources screen where it just says demographics. If I just kept it simple, I think that would make it a lot easier. This just gives you a little bit more fine-tuning, but we can certainly hide that aspect of it if a patient wishes to, or to open it if they want to fine-tune it. But generally, most patients, by default, if they invite a provider, it automatically provides full access to this list of resources.
The issue of scopes is still very much under discussion by the FHIR standard people. And this is going to be an ongoing issue, which I think we all could contribute to at the society, because remember that FHIR is being developed for the benefit of physicians. And it is only a few of us, me as far as I know so far, and I don't know anybody else, who's actively lobbying to have the FHIR API apply to PHRs and to the patient-facing side. And again, you'll see more about this. This is more regulatory politics than we're going to get into tonight. So what I'm saying is that what Michael's doing is yeoman's work to be adopting standards, the standards for OpenID Connect, for FHIR, for OAuth, this is the point of this demo is for people like us as physicians and some of the geeks that are involved in the standards to understand, and the regulators, to understand where this is going to go. This is nowhere near ready to replace a PHR, for example. Please go on, Michael.
Sure. So I'll go ahead and show you the provider viewpoint, and this would be similar if you if a provider had their own NOSH install for their practice. So instead of clicking patient, I'm a provider. So this actually, when you click on that, you'll see here is this MD-NOSH OpenID Connect server, which is tied to the MD-NOSH gateway, which I'll show you later. So it's a different OpenID Connect server, but this allows for the single sign-on. So as a provider, I can use the same username and login for every patient NOSH that I'm connected to, which makes it convenient, so you're not having to remember different passwords and so on to access multiple patient NOSHs. So this is the dashboard from the provider perspective. In the normal NOSH, in this space next to the logo, there would normally be a search bar for patients in your practice. So this is the one difference between a patient NOSH versus a provider-based NOSH. So I'm going to click on the active patient, which is this tester NOSH. And so this is the chart, and this looks identical to a provider NOSH only instance. And so on the left-hand side is basically all of the pertinent information, such as demographics, issues, which breaks down into past medical history, surgical history, problem lists, medication lists, their supplements and immunizations. allergies, and alerts, which are reminder system, which is a reminder system. There's also over here a list of encounters for the patient. Right now there's nothing in here, but you would see a list ordered by date of patient encounters, and then telephone messages in this screen. And documents is essentially PDFs of any outside sources that were scanned or faxed in, as well as test results. There's a way here to create a new encounter in the new letter. I won't go into this too much, but it's just to give you a general idea of what the provider sees, which is essentially a full-fledged EHR, but just purely for from one patient perspective. What I'm going to show you. Yes, go ahead.
When you add a medication, let's say, as a provider, where is this medication being stored? In the patient NOSH, the provider NOSH, or both?
So with this, with the patient, when a provider enters this in the patient NOSH, it first gets saved in the patient NOSH. If there is a provider NOSH that is linked to your practice, which when you get the invitation, once you accept the invitation and you log in for the first time, it will search for the NOSH that you are connected to. If you have a NOSH, a practice NOSH system, and then it will attempt to create IDs and secrets that allow background synchronization of the data, so that the provider NOSH will have the same information as the patient NOSH. But essentially the patient NOSH would be the first true, if you will, most up-to-date medical record for that patient.
So is it fair to say then, Michael, that the difference between a physician using, say, Epic or Cerner with a FHIR interface and a physician using a NOSH aware or an HIE of 1 aware PHR, patient-centered PHR, is this synchronization step that you just mentioned? When the practice, say it's a direct primary care practice, is using an HIE of 1 or a NOSH, whatever we're going to call it, aware EHR in their practice, then the synchronization is built in. Whereas if their physician is using a non-patient-centered EHR, they have a choice. Either they would be logging in or single sign-on in to the patient's EHR without any real synchronization, or that Epic, which is what you just showed, yes, or that physician's EHR, Epic or Cerner, would have to allow writes or back from the patient-centered EHR into their system, which right now is a few years off. Very few large practices are going to allow that. And if you look at Smart on FHIR, for example, they're not even trying to do that in the Smart environment. So, but that's a different battle. That's not a battle that involves the regulatory politics and standards politics around healthcare. That's simply a matter of you know, how the large systems are going to deal with the fact that direct primary care practices have this kind of capability if they want it.
That's correct.
Well, anything else? Or,
well, I'm going to go ahead and do a quick show of this MD NOSH gateway and what kind of an example this would be if a provider, let's say, doesn't have a NOSH system and they want to get a quick look at, let's say, a conditions list like past medical history or medications, and how it's tied into the patient NOSH that I just demonstrated. So as you can see, I just signed in, and I was already since on that's the nice thing about also being that you are that I was linked into the OpenID Connect server. When I clicked on signed in, it automatically signed me in without me having to enter my credentials, because I previously, just a few minutes ago, entered that in the patient NOSH. So that's actually one of the nice things about this system, and even though it's on a completely different domain. So what you see here is essentially a patient list of all the connected PNOSHs or patient NOSHs. So as you can see here, here's just the one that I just demonstrated, and then the idea is that with FHIR, this MD NOSH gateway, if you can imagine this being like a separate EHR, it's actually connected through UMA to the UMA server of the patient's server. And so if I click under conditions, it points out through FHIR the list of conditions that the patient has, which you saw previously on the patient NOSH. So even for non-connected physicians using proprietary EHRs, they can still get a quick look, and it's just a demonstration of the technology that FHIR can do in terms of sending out a list of medications. So here's an example of a medication list that was up to date on the patient NOSH. So that's my demonstration right there.
Well, I have a comment and a question.
Great.
The comment is that I'm thrilled at the idea that the concept is tying the clinical information to the patient rather than to a specific clinician or practice or institution. So the patient's pile, if you will, is the source of truth. Rather than trying to do all kinds of synchronization elsewhere, there is an identified source of truth, and that seems inspired. So that was my comment. The question is, at what point is there going to be something out there that people like me can fiddle with and give feedback about features that make our hair turn gray or make us jump up and down and sing, make requests and whatever? At what point do you start having a small group of people play with it and give you feedback?
Sure. Actually, it's active right now. You know, my EMR is hosted on GitHub. The code is on GitHub, and I'll be glad to send you the links after the Hangout session so you can see the work that's being done. Currently, I'm the only maintainer, but I would love to have more participants for input in terms of design, how it's used, so forth. And some of that work, you know, was all contributed by some of my early adopters who've used NOSH. And interestingly, I have some interesting people, some interesting practitioners from outside of the United States that were very interested in my system, mainly because it was open source, but also because of the user interface being something that they really liked from a clinician viewpoint. And so that was, for me, the design of the UI was the biggest impetus for my creating this EMR. So from both ease of use for a provider as well as for a patient.
I loved how much white space there was there. That it's, I didn't feel like I had fallen into a kaleidoscope of checkboxes. That I could see what was there in a moment.
Exactly. I use Epic, and I always considered that to be like, you know, you're controlling a nuclear power station, and any wrong click, you're just bound for disaster. And it just this is exactly one of the reasons why I created kind of simple like a Google type of design or material design. And I've also I'm currently creating a mobile version of NOSH, so it's still the same server, but it's so instead of looking at all the small font, it's actually visible on touch devices, again, to make it easier. And since it's web-based, any provider can access it 24/7 without having to VPN or all that kind of stuff. It's really lean and modern.
Peter, to a piece of your point, one of my strategies, and I'm glad, and Michael's as well, but to the extent that I'm trying to choreograph what's going on here, is the idea of allowing incremental updates, not just the way I mentioned it earlier, that incremental at the practice level, but incremental at the developer or the physician advisor level. So because by splitting out HIE of 1 from the patient's NOSH, even though even though they're right now being done by the same person and they're the same code, what I'm trying to do is to stick very closely to the way the standards would have to be so that the next person who has a PHR or an EHR would be able to work with you, not necessarily on Michael's code, but on their code, even if it wasn't open source, at least the HIE of 1 and the NOSH code is open source, so they would have that as a help. And so in effect, what this boils down to is if you found somebody to work with you, whether they had code or not, that was as competent as Michael, or maybe half as competent as Michael, you could make your own modifications. You could have either by modifying NOSH or by using whatever code this partner of yours would bring along, you wouldn't have to touch HIE of 1. Right now, HIE of 1 is not available. So Michael has done a huge amount of work around MITRE ID Connect, which is a huge piece of code and does a million things, which he's using on the practice NOSH side, etc. But my point is that as we continue, Michael and I continue to split this with using the standards of FHIR and hopefully HEART, which will be like the profiles or the ground rules for doing this with UMA, the net result is that literally people with just one developer or two developers will be able to manage a practice-specific version of either the patient or the practice NOSH.
And if it's sort of managed with the GitHub-like system, branches that get developed can be maintained as separate branches and can feed the initial branch. Stuff gets adopted. It's not an all or nothing phenomena anymore. And the stuff that's most useful will survive, but there's still a way to maintain niche products. That's a great model.
Yes, exactly.
And the whole thing changes when you make it non-proprietary, because all of us in this community are interested in helping the others. Not just because we start out working from the standards out, but because we start out with a very decent core of open source technology that right now is leading the FHIR stuff. FHIR is going so deep into worrying about what one epic instance needs to talk to another epic instance that they are lagging months, if not a year behind. I mean, they're doing great work in trying to develop a data model that's as complicated as all of HL7 and the nuclear power station or aircraft carrier that Michael mentioned. And that will go on. But the branch we've started down here really has not been explored before, this idea of actually doing what Michael has done.
Michael, did you do all this work yourself?
Well, I would like to say I did most of it, but I would say because of open source, all of the technologies that have exploded in terms of HTML, JavaScript, all the libraries that people have developed, I mean, if I did it from scratch, it would have taken eons. It took me about a year and a half to cobble everything together, so I use Laravel and PHP for the back end, and for the user interface, it's jQuery. And so It's one of those, that I was very familiar with that language code, and I was able to cobble it together, and then I just fine-tuned it from there on. But all of the, basically the net result was my work.
And this is actually it's a good reminder. Thanks for bringing this up. One of the things that I've been doing on the HIE of one side, started in the last month or so, is to make it very, very easy for a patient to own and install their own patient NOSH. Because obviously, if patients can't set up this gold, the gold standard for their own records in a way that average people can do it, then this breaks down. It all ends up being centralized, like every other PHR and EHR we have right now. And so I've been able, because of open source, I've been able to benefit from this project called the Freedom Box project, which is designed to give people their own personal server, if you would. And their goal is to make it as easy to set up as turning on a cell phone account. Basically, you need a credit card or you need to buy something like the cell phone, and then you just walk through in 15 minutes. You're done without any questions that require computer knowledge. And this project, it's run by the Free Software Foundation, actually, is actually quite far along. It's at version 0.7, and it's reasonably usable today. So the HIE of one part of what we're doing, what Michael and I are doing here, is based on another one of these frameworks, not Laravel, but in my case, Django, which is the Python version. He's using the PHP type framework. And again, the standards are being done, the standards work is being done right now. And because these are standards-based systems with respect to UMA, because there's no FHIR in HIE of 1. HIE of 1 is only UMA. These things are working, are designed to work together, even though they're completely different people and code frameworks being used.
And I see this as a start, of, having, in the age of people, worried about their personal data in one centralized area. I think this, really is an example of a model where we have a decentralized, centralized type of system where people are connected but not having their data stored in one place. That if there was any security breaches, you're exposing them to thousands of files. You're basically only exposed to one, and I think if we show that we can see, we can do this from a medical record model, I think it can be pretty revolutionary.
It sounds fantastic. So how can we help you?
Well, it would be good if we can spread the word, spreading the word to other doctors and about the project. I think that the more adoption and the more awareness of it, and even though, we're coming through right now at the demise of meaningful use and trying to figure out where to go from there, it's, it's not too late, I think, in terms of looking at other novel approaches to answer this question of interoperability that a lot of the physicians were hoping that it was going to come true with meaningful use, but it never came to fruition. And so this is if spreading the word, and if you want to help contribute on GitHub or to provide ideas, feel free to let me know. If you want to take a hand at coding, I'd be glad to help too.
I'll answer that a slightly different way. In order for something like this to grow, we need two kinds of contributions. We need sponsors in the strategic sense. Obviously, money is always nice, but we're not businesses. We're not set up to take money. But a strategic sponsor, maybe a very progressive insurance company, for example, or an employer that sees this as a form of charity, a large employer that wants to sort of have their name lent to an open source project, that kind of thing. This is how, or Mozilla started, or Linux, or anything else. So identifying a sponsor, it wouldn't have to be a giant amount of money, but somebody that sees this as a public service would really change the nature of what we're doing here. And then the second thing is to think of adopters. I mean, in other words, people that have real patient data, practices, doctors, whatever, that, HIE of 1 is still pretty green, but Michael's stuff, NOSH, is being used. And, if there was an organization that said, look, 9 months from now, if we can reach these milestones, we'll install this, and took that kind of an interest in it, even if it was on a moderate scale, that would also be very new, because right now we don't have any, I don't know of any institutions that are willing to lead with these advanced patient-centered concepts and lend their name as an institution to working in this domain. And that hampers my work in trying to promote, regulatory change and standards evolution in this decentralized patient-centered direction, right? Because, yeah, sure, I have patient privacy rights as a nonprofit, the advocacy group behind me, but that's not the kind of stuff that happens in like the fire or the healthcare space, where you have all the institutions or Argonaut vendors, etc. So these are the two kinds of things that when we spread the word, as Michael said, it would be very useful to have innovation on the sort of value chain or the adoption side of what we're doing. You're on mute.
Ready to use now. Michael, your software is ready to use right now.
Yes, it is. It is, like I said, it is being used by some practices right now, and you can certainly try it out if you want to install it on your own. It can be installed on any Linux, Apache, MySQL, PHP setup or virtual machine. And so you can certainly try it out, and there's also a demo site that I'll give you the links to that to my project, so it actually you can actually run a full-fledged practice on a full-fledged demo as well if you don't want to install your own system. But yes, it is ready to use right now.
It would seem to me that one potential group of adopters would be employers who are doing, that's a big deal now for reasons that escape me, that are doing employee wellness stuff. And that's a circumstance where they might very well want to be able to do their employee wellness and have the employees able to access and participate. That might be a very strong selling point in that market niche. And you might be able to ramp up from some smaller employers to larger ones. I mean, you wouldn't start with GE or Ford, but
right.
Proprietary systems. But
Peter, I've tried that kind of thing because this is what I do. The problem is that employers see dealing with medical stuff as a distraction. So if they're small, they really can't afford to innovate in this unless they're really, really committed to changing medicine. And if they're large, they go through benefits managers that are big centralized operations that won't deal with projects that have limited support type of thing. So the employers can be very valuable as strategic sponsors because employers do charitable things, not just for their employees, but maybe it's strategically valuable. They're selling, a drug or a medical device or something, and they want to provide a given profile. So that's that's maybe the kind of employer that we should be looking for.
Yeah. One alternative, and because I mentioned that I work for a direct primary care practice, and this one is actually employer-based in the setting, in the meaning that we get our members through a large pool from a say one employer source, and so so it's not we're not attracting just individual memberships from patients. So this is one avenue that I'm seeking to try to take some advantage, if you will, with my position in that organization to see if there's an interest in utilizing NOSH, and then to expand that to a patient NOSH type of setup where the members or the patients really have control of their medical data, and that we would be using a single sign-on solution, for instance, and that the patient would have their one true record and be a demonstration of that kind of model.
Well, we're getting to the top of the hour. I think we've covered a lot of ground. Other questions, or should we do another one of these and invite other people? Where do we go from here?
I think it's very important to have the contact information. So that can come by email or however you want to do it, but that's critical.
Yep.
Well, I will put the contact information on the website, with the recording of this session. But I think Michael and I are both real easy to find on GitHub or in general. So Googling HIE of 1 or NOSH finds either of us without any problem.
Okay.
Yeah, my next task is to digest this hour. I have to spend a little time letting it integrate.
Well, I appreciate you guys. I appreciate you guys doing this late session. Unfortunately, me being in the West Coast does make it a little bit difficult to find the right time.
If we're going to sell this to patients, as users or adopters, we're going to have to figure out a way to present this with many fewer acronyms, because this is not my first rodeo, and I've been doing stuff like this for a long time, and I'm struggling with all of these are new acronyms and not the ones I use every day in the office. They're a different language. And for patients, it's going to have to be a more patient-friendly language. I don't know exactly how to do that.
Well, for me, I've thought about it. Essentially, what I see it, from a clinical perspective, patients just think that somehow we are connected to all, like my practice is connected to the hospital and so on, and somehow there's just only one record of them, which in reality there's probably 10 or more. And so having this concept of just one record for a patient is really powerful to them, because in reality that that one true record is the patient record, and everything feeds to it, and not the other way around where it's disseminated to different places with different information for one patient. So
yeah, I started using the term HIE of 1, which some people think is absolutely horrible, because nobody knows what an HIE acronym is except for people, a few people like us. But it does have this aspect to it of the of 1. So maybe the one thing we need next is to figure out a name for this, patient-centered health information architecture, or the patient-centered health information economy, which is what the New England Journal editorial was today, doesn't quite cut it either. So yeah, I do think we need some, at least one name that we can hang around the concept, and then the rest of the, the rest of the jargon can disappear as long as we can communicate this thing that Michael just said, that it's you and you own it.
Most important. Well, I will be in touch as long as that. Now, how do we get the recording to spread?
Well, that's not my area of expertise. I will see if I decide to edit the dead air before we started, or if I can. And in any case, it is public. It's already public, and I will tweet about it. And if you guys wanna, I think it's better if one of you two comment about this in the society rather than me. I've been pushing this, so if you want to mention it, at least to the rest of the members in the society with whatever comments either or both of you want to make about it, I think that'll help spread it quite a bit. You might just wait, 15 minutes or a half hour and see what it looks like, as the public thing. Make sure it's up there. But I'm pretty sure it's going to just be saved automatically, and you'll be able to link to it, or the link will be the same as it is now.
Yeah, I'll start talking about it tomorrow. I'll let it ripen overnight. My day starts at 5 a.m. in the morning, so I'm getting pretty close to a dead battery here.
Okay. Well, thank you so much.
Thank you, Michael.
This was good. Learned a lot.
Thank you,
Thank you, Peter. Thank you, Michael.
Good night.
Good night.
Good night, Adrian.
Good night now.